I am going to introduce the Right Honourable Patricia Hewitt and Professor Claire Fuller. Patricia is Chair for Norfolk and Waveney Integrated Care Partnership, and she's also author of the recently published Hewitt Review, an independent review of integrated care systems. I'm sure all of you have read it. Patricia gave an absolutely amazing presentation at the NHS Confederation just last month. Really excited audience, and she had a packed audience. And Claire, of course, as you will know, is not only chair of the Fuller Stock Tape Report, but she's also chair of the CEO, and she's also a GP there, so very, very awake. Very, very awake. That was one of my questions to you. What's keeping you awake at night? So I've tipped that one. So what we're going to do is Patricia and Claire are going to have a fireside chat. So they're just going to sit and chat and for about 15 minutes about their reports, about how they see them playing out, about what's keeping them awake at night, and perhaps about where they see us being in 5 years' time. So I'm going to hand over the floor to them, and then we'll take questions and answers from you, the audience. Thank you very much. Enjoy the show.
Right. Well, Angela, thank you very much indeed. Now, Claire and I have not teed this up.
No, we haven't. Haven't helped us.
But we've each come along with, I think, one question to ask the other. And of course, there are so many things we could discuss about the process of doing an independent review, which itself is fascinating. But I thought we'd look to the future. What makes you, look, your vision of integrated neighbourhood teams and the whole thing you set out for us in your review, which I think everybody loves and we're all signed up to. What makes you really optimistic at the moment?
So the fact that the report was published a year ago and that we're still here talking about it, and that all 42 systems have submitted their baselines, and locally we've got Pramit sitting down the back up there, who's from my neck of the woods, where we are implementing properly the integrated neighbourhood teams. It is working, and so we are driving down demand, we are reducing escalation beds, we are reducing headcounts across urgent care pathways. So it was a vision that was based on thousands of conversations, like as you did, that meant it was very much built out of experience and out of everything was based on stuff somebody was doing somewhere. But when you stick it all together, it is the fact that it is deliverable and it is doable, I think, is the thing that gives me cause for optimism.
Yes.
So I was going to come back to you. So I've done the classic magic wand question. So you are just published rather than being a year on. So if I was to give you a magic wand, what is the thing you would like to come back in a year's time and then go, I have reason to be optimistic because this has happened this year as a result of my report?
Do you know, the one thing would be a real understanding from all the national bodies, ministers, NHS England, everybody else, that top down is not the way to get the transformation we need. And as a result of that, a real shift away from managing each part of the system vertically, acutes, not just primary care, but GP-led primary care, opticians, dentists, community health, social care, apologies to anyone I've missed out, mental health. Every single bit is being managed in a separate vertical silo, separate targets. Now, if we were moving away from that and had started to create, payment systems that linked it all together, targets that could only be achieved because we were all working towards them, align the incentives in the jargon, but everybody pulling together and the centre realising that's that culture, but also process change.
Yeah.
If that was starting to happen, I would be over the moon.
So we were having this conversation just now before I sat down around actually it's the role of provider collaboratives versus the role of ICSs, and actually the need to do end-to-end pathways and to stop this setting up pilot projects with little pots of money and stop sending down last-minute pots of money. It is that the money is the money, how are you going to deliver the activity across that whole pathway? But actually, so we were talking specifically about an ophthalmology pathway, but actually optometrists, we need to move to a land of having optometrists as a single provider collaborative, interacting with the trust provider collaborative to deliver that whole pathway. It's not a separate contract. It's not a separate pot of money. It's all one.
Yeah. It's all one.
Yeah.
And indeed, integration. Yep. It's all one.
Yeah.
So that is classic, and that's why actually the other thing I would love to see in the next year coming out of the review is a really radical approach to a new set of primary care contracts, because the GP one is most obviously flawed, but actually we need change across that part. I have to say, I don't myself approach this simply from the point of view of the provider collaboratives and what's the provider collaborative structure we might need. I mean, that'll vary anyway from place to place, because I would very much start from what do we need as residents, with generally friends, neighbours, family, carers. What do we need as communities, particularly the most disadvantaged? And therefore, what's the right combination of people, skills and organisations? But that will include the voluntary sector.
I include them in a provider collaborative.
But you can end up with a provider collaborative that gets bigger and bigger. So that's the sort of structure. But in some systems, including ours, the integrated care system, now statutory, or the Integrated Care Board, is playing a really critical role in getting the providers working together.
I think that's right. So I think so. In terms of there is a role for ICBs and ICB executives in making sure we've got the right skills sitting within whatever bit of wherever the delivery is happening, and that would particularly if you take primary care as the example, I believe it's my job as the ICS chief exec to make sure that we support our practices, support dentists, optons, pharmacy, and of course I always do audiology as well, don't I? But to make sure that the right skills are in place to make sure the right development can happen to bring those teams together. But in time, that support should move away so that you then leave fully functioning teams to deliver. So I can see that the role of the ICB with time becomes less.
I think that's probably right. I think probably right. But let's see how this all develops, because I think it'll look very different in a year's time, 5 years' time. And I think it'll go on looking different in different places.
I think that's right, depending on your geography.
But also the maturity of relationships. And we know that individual trusts, can be up for quite a long time and then something happens and they go down, or vice versa. So that kind of change will go on. But I do think one of the things you and I started talking about in the latter part of my review, but there was never the time to complete the conversation, is this business of how far the traditional GP partner-led practice is going to be the key unit, at the primary care level. And my sense, looking at the data, but also just what is happening across the country, we know that fewer and fewer GPs want to be partners. And we know on the one hand, there are wonderful GP partner-led practices. Yours is one of them, but there are many, many doing fantastic work. And they're operating at a scale and with the professionalism which enables them to make wonderful use of data, have superb telephone systems so there isn't the ghastly Monday morning rush and all the rest of it, and they fund their own investment and development. And we know that at the other end there are practices, often in very disadvantaged areas, where, the premises are wholly unfit for purpose, but they can't do anything about them because they're in negative equity. And they haven't made any money for years, really, as partners, and there's nothing left to invest. And then in the middle, you've got some who want to remain as practices, but aren't necessarily doing anything terribly innovative or of the kind that you and I and everybody else would want. And I just think we should be We need to change that framework. We need to give GPs who want to work as salaried GPs much easier routes. We should give firm practices like Medicus much easier routes into large group practices, which are very hard to achieve at the moment, and be much more agnostic about what the business model is, if you like.
So I would go back to function first before we do form.
Precisely.
Yep. So I think when the partnership model works, it is unbeatable. And so we're fortunate in Surrey that we've still got a vibrant partner landscape, and you mess with that at your peril. It works, and it is the best way to work, and it's the best way to deliver care. What we've then got is areas, like you say, where you cannot recruit partners, you cannot recruit the model. And I think part of the thing that worries me about that is that you then get other people coming in and trying to deliver the care, but we haven't defined the operating model within general practice. So we haven't said what we expect to happen in a practice. There's a bit of a core contract, there's a bit of this, and there's a bit of that, and there's 39 different funding streams. Yes. So I think we need, and I think the primary care access recovery plan has gone a long way to defining Pramit will call it inbound and outbound. So the inbound, so patient-initiated care. And I think we've got a good blueprint that has been signed up to, has been well received, and actually when people are implementing all the bits of the primary care access recovery plan, is having impact. But the bit we haven't talked about is what is the bits that we expect practices to do as practices. So the outbound stuff, what do we think we should do at the most local level? And once we've defined that, I would then be more confident about defining a contract that other people could do that we're not partners. But the neighbourhood teams wrap around the practices, because if you lose the practices, you lose continuity. And continuity is the thing that keeps the health service ongoing.
Indeed.
And so that's why I would protect the practices and protect continuity, and removing some of the transactional access does that. The neighbourhood teams does that by identifying the most complex people and putting team-based continuity around them, and then dealing with health inequalities to actually upstream drive down some of that demand. But ultimately, that one-on-one relationship between a doctor and a patient, that you will have your own stories of consultations that will have changed your life or your family's life, and we all remember that GP. That is the bit that keeps the NHS working.
Yes and no. I mean, where you have got all over the country some wonderful practices doing superb, not just reactive inbound care, but proactive risk-based population management and all the rest of it. We have some wonderful ones in Norfolk and Waveney, and I think it's true in every ICS. So you absolutely do not want to sweep them away or change the model in a way that's unhelpful. Now, some of those, I use the Medicus example, but there are many others in your and my report and elsewhere. Some of those are large-scale group practices where the current contract makes it unbelievably difficult to operate at that kind of scale. So we need to fix that and remove those sort of barriers. I think one of the mistakes we make in the health service is defining the operating model we want at, in this case, the unit of the practice. I want to think about and really have a good set of outcomes that we want for our communities and our patients. Now, that may be delivered by an integrated neighbourhood team where the practice is absolutely the core, but not necessarily.
No, I agree. But
unless you start with the outcomes rather than what is it the practice has to deliver.
So there's not a single person that would ever disagree we want to improve patient outcomes and look after people better. We all say, and everybody will say we want to improve health inequalities, and I think we say it often. But we now need to move underneath that and go, actually, how are we going to do that? And how do we do that? And by clearly, and then we always get hung up on, or we just count processes rather than outcomes. But actually, it's very hard to define true outcomes and to then row them back. And they need to be outcomes that are meaningful to the population, which may be different depending on who you are and where you live. But I still think there needs to be something, and practice may be the wrong word. It may be that may be unhelpful, but people need to be able to know what you can access from your home, and that's what I call primary care. So that includes the practice, the dentist, the high street stuff. It includes 111. It includes 999. It includes the sexual health. It includes the school nurses.
That is so much further than a private.
But that's what you access from your home. But then, what can you walk to from your home if you need to go and receive care from somebody? So I think you should be able to walk, to have your long-term condition managed, to have your smear done, to if you want to be investigated for something that's going to require multiple consultations. But if you want something more complex, so say you need, I don't know, like your travel vaccinations, or if you need to go and have spirometry done, you might have to travel a little bit further within your neighbourhood. But I think it would depend on you. It will look different in Cornwall than it look in central London.
And in Norfolk and Waveney, trust
exactly.
me.
But that's why I want to go back to defining what we're doing. Yeah. Yes, exactly.
Okay. I mean, I think there's masses of agreement between us, but for me, the really important thing that comes out actually of this conversation is how different it is in different places, different communities, but also different individuals. I mean, what you or I can walk to is very different from what, the elderly person I ring once a week can walk to, which is just outside her front door if she's lucky that day. And thinking across the whole landscape about how we meet people's needs. I think that's what we're both saying. And how you get there will vary considerably, which comes back to the point about, please don't try and design and dictate all this from the centre, because it's profoundly unhelpful and ultimately wasteful, actually, of time, money and energy.
I feel like a little bit of a spoiler because it was really getting going there, but equally said at the outset. Thank you. Really want to start to take. I've got a load of questions here, but I think I want to open it up for the next 10 minutes to questions from the floor. So, do we have some questions from the floor? Yes.
And tell us who you are.
And yes, please tell us who you are, where you're from. That'd be great, and stand up so everyone can see you. Thank you.
Hi, good afternoon, everybody. Thank you very much. I'm Dr. Shriti Patani. I'm a consultant in occupational medicine and the expert in occupational medicine for NHS England, and also a GP for 25 years. So,
that's nothing.
I'm just warming up. So I guess with my occupational health hat on, the question is that with ICSs, how can we use that to support our workforce, particularly around recruitment, retention and health? What are your views? Thank you.
Thank you. Who's going to take? Can I take that one? So it's a subject very dear to my heart. So because I think it is something that is done better in trusts than it is done in the wild. And it is something that we need to improve. So locally, there have been a number of death by suicides of GPs, and we are not looking after our GP workforce, and in particular, and it's one of the reasons why I think that I continue to champion the partnership model. So the death rate with partners is higher than of any other part of the profession. And we neglect our partners, and it is our partners that are carrying such a weight of responsibility, and I think they get neglected and they get overlooked. So we've just run there's the NHS staff survey that you run within all the organisations. We've just run it in primary care. Well, in general practice, if I'm being correct. Lowish uptake, but just really interesting. And there's lots more we have to do. So we need to protect our staff from abuse. We need to look after our receptionists. You will still get every day in every reception in this land, somebody being phoned up and gone, if I die today, it will be your fault. And the new one is, I'm entitled to an appointment. I will sue you if you don't give me one. So and we do not look after people properly. So we need to make sure we've got the right pastoral care in place. It is really isolated in practice as well. You can go all day and just see patients walking in and nobody else. We need to connect people, and we need to connect them vertically, horizontally, and in their geographies. So, we've got the brilliant Next Gen programme that Nish Milak set up. We've got the first 5 from the RCGPs, we've got the Phoenix. We should be doing something for people in the last 5, or, you know. And there was a thing for doctors leaving secondary care, where they're all now asked. So there's a beautiful policy piece coming out from NHS England about secondary care doctors over the age of whatever to have an exit interview with their ROs, but no mention of what we were going to do in primary care. So there's just some systematic things, and I'd love to have a chat with you about how we can do that differently. But we need to look after people because people are at risk.
Yeah, and it's interesting that you raised that, because as I was listening to the conversation, I was thinking, you know, GPs have taken a real battering post-COVID, and it's just been relentless with the Daily Mail in particular. And, you know, when you share that piece about, you know, partner suicide, you know, they are bearing the weight of that, and they've spent their lives building that practice, and just all of that weight and the kind of thing. So my question there was then going to be, do ICSs actually have an occupational health strategy?
No.
Well, yes and no. I would say, actually...
We don't have a strategy. Well, we don't.
That's interesting.
Yeah, no, we don't.
Let's take an action there, because we're going to write this up. So,
Well,
you know...
Our Integrated Care Board and several others... I mean, this is a really live conversation. We haven't necessarily called it occupational health as such, but what we are talking about is how do we, both as an Integrated Care Board, so NHS, Norfolk and Waveney, and as a system, how do we create a culture across the whole, all our partners, where everybody, whether they're a GP partner, a GP receptionist, a social care worker, a community health worker, working very isolated in people's homes, receiving horrendous amounts of abuse, and with none of the generally IT tools to make their life a little bit easier. So there's all kinds of issues in pretty much every part of the system. How do we create a culture within each organisation, but across the whole system, where people are really thinking about working as one team, around, it may be one patient, one family, one community, one pathway, whatever, and we're developing people together. So as well as those GP programs you're talking about, we're trying to pool bits of our training and development budgets so that people can spend some time, social care staff or commissioning of social care staff can spend some time with the NHS and vice versa, and in the voluntary sector, so that we all understand the huge strains, the risks different people are carrying, and.
Great first question. Take another question. Thank you. So, gentleman there, and where you're from.
Thank you. Councillor Paul Carter. I was leader of Kent County Council for 14 years and sat on the STP, stood down about 2 years ago, but continued to take a significant interest in the new ICSs. Having sat on the STP for many years, very little was achieved. Therefore, I'm neutral on whether the ICBs and the ICSs are going to actually deliver and what's different about it. My sort of reflections on the STP was of the fact that the Acute Hospital Trust always nicked all the money and primary care got a very raw deal. I think that acute hospital budgets should be ring-fenced and capped. And of course, if you read Professor Chris Ham's report, the fact that a lesser percentage of money goes into primary care now as a proportion of the NHS budget, with an elderly population with multiple illnesses and the demography going that way, that must surely be redressed. And the thing that bugs me a little bit about ICSs and ICBs is on the ICB board is the Director of Social Care, but no democratic representation on those ICBs, which I think is a very retrograde step. Local government has an enormous amount to offer through public health and its responsibility for social care, and democratic scrutiny of where the money goes, how the money flows, the commissioning, the procurement. Very, very opaque at the moment. That lid needs to be lifted, and it needs to have the scrutiny of the democratic members of local government, which have a lot to offer in their procurement and commissioning role, as well as obviously the other ones.
You're getting a lot of nods there from the floor, and just conscious of time because we've got one more question, I think. Yeah.
Okay. I would just say that although, I mean, I think in many parts of the country, STPs, if we hadn't had them, COVID would have been even worse because nobody would have been talking to each other at all in some systems, maybe not in yours, but it made a difference. But just remember that the new Act, only a year old, gives us integrated care partnerships. Now that is critical. Local government led, the place boards, local government led, bringing the entire partnership together. I'm actually the deputy chair of our partnership. The chair, who's a senior local councillor, is on the integrated care board. It varies from system to system. Yeah. But actually, don't think that the integrated care board equals the integrated care system, because it doesn't. And if you try to put every function and everybody onto the integrated care board, you actually won't create a functioning system. Local government, including the HOSCs, are critical to the transparency and the local accountability that we need, some stronger than others. Recommendations in my review as to how we might strengthen them have actually been accepted, and we're starting to see some action there.
Yeah. So I think I'm going to be bossy on this one now. I don't want to make my co-chair's life any more difficult, but I do have one more question, and I did see very vociferous nodding from what you were saying there from some of our speakers that are going to be talking later, from Angela and Sarah Louise over there. So we'll pick up on that. So who had the hand first? I can see a gentleman back there. Ros, you've got your eyes on. Was it somebody over here? Oh, they've disappeared now. Well, there's a gentleman there who was nervously putting his hand up. He looked nervous, sorry. Perhaps it's just that I'm short and I can't see. That'll be it.
Lovely, thank you very much. Josh Hutchison, one of the partners from Channel 3 Consulting. One of the interesting things, so I really like what you were talking about, the full pathway end-to-end design. And we talk about primary care and we talk about the acutes. But that social care aspect, which looks at sort of homelessness, the mental health side, that at present seems to be rather underfunded to bring those systems through. How do you think we address that at sort of a national level to drive more funding in social care? I'm sorry, that's a horrible question, but
no. Well, you don't address it at a national level. It's a local conversation, isn't based on local needs. So the point of the integrated neighbourhood teams is that you need to understand and know your population and know what your population needs are, and then provide the right care. So Pramit will talk. Sorry, Pramit will talk later. So I'm not going to steal his numbers around. But actually, if you understand your population and where the greatest need is, you may need more children's services depending on demographics versus needing much more elderly or more mental health support. So that's why I think Patricia's point earlier about it's not a top-down bit, it's a local conversation, and in those local place and neighbourhood teams is where your social care and your children's services and the voluntary sector need to sit and come together. Yeah.
Can I just add, Josh, because it's a really important point, there are things that need to happen at a national level. Yeah. And we, as a society, we need to have a much more honest and grown-up conversation about how much we are willing to pay, whether it's through our taxes, through national insurance, or as individuals, or some of both, to ensure that older people and ourselves, as we become old and frail, actually get a quality of care that we think is acceptable in a decent society. And that conversation has been started and stymied over 20 years probably. So we don't have a proper funding settlement and we don't have a social care workforce plan. We need both. But there is wonderful digitally enabled innovation going on in the social care sector, which also makes me optimistic that at least some great things are happening, despite the lack of some of the national policy things we need as well.
And we will be talking, we've got a whole session on digital and how that might support. So I'm going to bring this first session to a close. Thank you so much. I mean, I think we could have just sat here all afternoon, and I think there would have been lots of questions coming all afternoon. So if I can ask you to show your appreciation, and then I'll introduce our next session.